Okay, I do want to clarify something. I misspoke before talking about the 4 types of shock. All shocks are vasoconstriction. The only one that's not is the distributive shock. That's why distributive has warm extremities, because it's vasoconstriction, vasodilation in distributive. All other 3 cause vasoconstriction. So that's why they're cold, clammy hands, because of the vasoconstriction, but distributive, wide open, anaphylactic, histamine dump, wide open vessels, vasodilation with distributive, but all 3 other ones are vasoconstriction. Okay, so we have some case studies to go through. So first one, so a 31-year-old male with a history of IV drug use comes to the emergency room complaining of shortness of breath. Okay, he said it's been going on for about 1 month history of intermittent fevers and night sweats with a non-productive cough. Initially, shortness of breath was only with exertion, but now he has shortness of breath at rest. And when you see him, moderate respiratory distress when you look at them. Okay, so he's got an IV drug use. What are we worried about with that stuff? Endocarditis, the infection of the valves. He's got fevers and night sweats, so we know it's an infectious thing going on. Let's see what else shows. Vital signs, temp 39 degrees, is that normal or high? High. Heart rate. Respirations, high. Well, right on the edge. O2 sat, low. So we got high blood pressures, fevers, a little bit tachypnic. O2 sat is low. Physical exam, lungs, CTA bilaterally. What does that mean? Clear to auscultation. If you're my advisee, all you have to do is write that on your notes. Okay? No WRR, wheezes, rails, or rhonchi. Okay? And that's absence of abnormal lung sounds. So we know the lungs are clear, so the lungs are okay. Chest x-ray, diffuse interstitial infiltrates, characteristic of pneumocystis pneumonia. Okay. So what is the underlying disease most likely responsible for this man's susceptibility to pneumocystis pneumonia? Who gets that type of illness? We learned about AIDS, HIV AIDS patients. Okay, here's your HIV AIDS case. IV drug use, sharing needles, that's risk factor for AIDS. Okay, what is the pathogenesis of the immunosuppression caused by this underlying disease? What does HIV do? Any cell that has the CD4 receptor, okay, those CD4 cells, okay, attaches to the CD4 cell, injects its contents in there, it replicates inside the cell, and eventually cell dies, it opens up, and all the little baby HIV viruses break out, and they go and infect the next ones. And that's how it spreads. But again, CD4 receptors drop, those counts receptors, you have no immunity anymore, and you get sick. History of the disease, remember it's latent for a long time, up to 10 years. The symptoms that they present with are pretty nonspecific. LAD, fever, weight loss. But then the more serious ones start to happen later on as the HIV goes into full-blown AIDS later on. And these weird ones, PCP, cryptococcal meningitis, CMV retinitis, all these weird things that don't happen in normal people because they have a normal intact immune system. They can handle it and get rid of it. HIV can't. Next one. 45-year-old male presents with history of shortness of breath, irregular heartbeat, and hemoptysis. Okay. Notes that over the past 2 weeks, he's become easily winded with minor activities. So the breathing is becoming a problem. Energy is becoming a problem. Reports coughing up some flecks of blood. That's your hemoptysis. Fast heartbeat on occasion, pounding in his chest. Those are our symptoms so far. So let's look at our medical history and our physical exam. Past medical history, being ill for several weeks after a sore throat in childhood. What are we worried about with that response? Rheumatic fever. Okay. Vital signs, heart rate 120 to 130. Is that fast? Yes. It's fast and irregularly irregular. That means that the beats come at an irregular time, not a normal, nice heartbeat every second, 60 beats per minute, so on and so forth. Usually indicative of AFib. Whenever you see irregularly irregular on a cardiac exam, assume it's atrial fibrillation. That's what it's always going to be used for the most part. Physical exam, JVD is noted. Is that a right-sided failure or a left-sided failure problem? This is right-sided. So I just put right heart failure. Lungs, rails at the bilateral bases. What do rails indicate? Fluid. So there's fluid in the lungs. Is that indicative of right-sided failure or left-sided failure? This is left failure. Left side can't pump. Blood backs up into the lungs, causing breathing issues. Cardio, irregular heartbeat, soft diastolic decrescendo murmur. So I said it's diastolic. What murmurs are in diastole that we learned about? Mitral stenosis, aortic regurg. So now you got down to 2 answers. Mitral stenosis or aortic regurg because of that soft diastolic decrescendo murmur. Murmur loudest at the apex. Apex is down here. What valvular area do you listen to right here? Mitral valve. That's why you have a left lateral decubitus. You're trying to get that mitral valve as close to the wall as possible so you can hear it a lot better, any of these mitral murmurs. So you do your 4 valvular areas, you come to this point, oh, I hear a little bit of murmur on this side. Why don't you lay on your left side? Let's see if it gets worse. Or sounds worse. EKG, atrial fibrillation, and your left atrial enlargement. So we have hemoptysis, left atrial enlargement, irregular heartbeat, signs of right failure, signs of left failure. What have we learned can cause all of these things? Mitral stenosis. Mitral stenosis is a fixed obstruction in the mitral valve. It's not a heart failure problem, but it mimics a heart failure because blood can't get through, backs up in that left atrium. That's why you have left atrial hypertrophy, because the blood is getting stuck in the atria. And what does the atrium have to do now? Atrial kick, right? So what sound may you hear now? S4 for that atrial kick to help with filling. Because we have a stenotic valve, we got to get it through. Blood backs up in the lungs, you get shortness of breath. But then it backs up even further into the right side of the heart, and it can cause right-sided heart failure symptoms, and mitral stenosis is one of the things that can cause right-sided heart failure by itself. That's why you have signs of right-sided failure and signs of left due to the mitral stenosis. So we already talked about that. Mitral stenosis, hemoptysis, blood backs up in the lungs. Those pulmonary capillaries don't like very high pressures, and those pulmonary capillaries pop, and they break. And that blood goes into the lungs. That's why you cough it up. What other symptom might they have with a mitral stenosis that I haven't mentioned here, but there's one other symptom that's pretty unique for mitral stenosis. What? Someone said something over here. Not mitral valve prolapse, that's a regurgitation problem. So one of the things mitral stenosis can cause is a hoarse voice called Ortner syndrome. Why?
Because it's on the laryngeal nerve.
That left atrium gets large and it pinches the left recurrent laryngeal nerve, and therefore you get a little bit of a hoarse voice with that. That's one of the causes for it. Yes?
When you're auscultating, the rails in the lungs, is that specific to mitral stenosis?
That could be any if I just said patient has fluid in the lungs, what are some reasons you can get fluid in your lungs? Mitral stenosis is one of them. Left-sided heart failure is another one. So there's reasons for having fluid in the lungs. As you go through all your CMS courses, you'll figure out what other diseases can also have pulmonary edema as well. Okay, and we talked about that. They can get a clot due to the atrial fibrillation. The neurological complication, again, left atrium forms a clot, it breaks free, goes out. Yes?
Was the childhood illness that he had relevant at all, or was that just
Well, remember, rheumatic fever attacked what valve? Mitral valve. So the fact that he had rheumatic fever as a child leads to higher risk of developing mitral valve problems later, and he got mitral stenosis due to the rheumatic fever as a child. Why rheumatic fever causes mitral stenosis?
When I think of rheumatic fever, sometimes I'm just like infected endocarditis and that's it, but I know.
Well, it just, anything that can, if it infiltrates the valve at a young age, remember over time that valve will calcify now due to repair. And when calcified valve, it's not going to open properly anymore, causing the stenosis to occur. Okay. Next case, 55-year-old male presents to the clinic with chest pain. Intermittent substernal chest pressure that radiates to his left arm for 5 months. What should you ask your patient if they say they've had an intermittent chest pain for 5 months? What?
Why'd you come in now?
Why'd you come in now? You've had chest pain for 5 months. What changed that you're coming in now? Does it get worse? Are you just like, well, my wife is nagging me, I gotta get checked out, whatever it is. Why are you coming in now? You've had it for 5 months. Pain occurs mainly when he exercises vigorously and is relieved with rest. Denies any other symptoms with it. Past medical history, hypertension and hyperlipidemia. Medications, he's on atenolol for high blood pressure. Get in the habit when you are looking at your medications for your patient, attribute every medication to a diagnosis. Why are they taking that medication? You will have patients when you go talk to them. This is why those of you who have seen for like OSCEs and skills exam, I'm like, you have to talk in layman's terms. You can ask a patient, do you have diabetes? They're gonna say, no, I don't have diabetes. And then you look at their medication list and they're on metformin. Like, why are you taking metformin? Like, oh, I got sugar problems. They don't know what you're saying. That's why you can't say hypertension. Do you have any blood pressure problems? Oh, you're on the Cinepril. Why are you taking that? Oh, my pressure's high. Okay, you see, like you can't ask normal medical terms. You have to be the translator in your brain because they won't know. That's why you coordinate the drugs with the diagnoses so you know you hit them all. Father died of MI at age 56. Is that significant? Yes, that's young. So, social history, 50-pack year smoking history. He's trying to quit. Eats low cholesterol diet. BP, is that well controlled? No. So yesterday we talked about how do you take people off medication. If they're on atenolol and their blood pressure is still 145 over 95, now we don't know the dose of the atenolol, but do you think that atenolol is effective for this patient? No. It's not working. Either you need to increase the atenolol or you add another medication. All of that discussion you'll have with Dr. Wood and Professor Muniz in cardio, for example, but getting you primed to figure out where we're going with all this stuff and how your brain needs to start thinking. So what are his risk factors? Smoking, family history, Hypertension, hyperlipidemia. Do we know his weight here? I don't think we do. No, we don't. We don't know his weight. But again, obesity by itself is a risk factor as well. So BP is okay. Pulse 75. What's going to happen with this beta blocker? What's that going to do to your heart rate? Decrease it. But you're at 75 right now. You can go a little bit lower. So in this case, you can increase that atenolol because their heart rate is still high enough. If their heart rate was 60, 55, don't increase the beta blocker. What's going to happen to that patient? They're going to pass out because you're going to drop their heart rate too low, their pressure, they're going to get up, they're going to get lightheaded, and they're going to pass out. Okay? That happens because you increase their beta blocker. Just turn in your license. I'm just kidding. No. Honestly, it's not if, it's when you're going to cause an adverse event. It's going to happen. So just be prepared. That's why you're all in school right now. Make your mistakes now, you know. So diagnosis, again, so he has stable angina because it only happens with the exertion. Didn't mention anything in that question about chest pain at rest. Don't assume things on your questions going forward. All the information that you need to answer a question is in the question. Don't try and theorize, oh, they didn't mention this, but it could be. You're going to get yourself in like a circle in your brain and you're not going to be able to answer your question. The information is there that you need. Some of it may be superfluous, that you just extra information thrown in there. Usually ages are like that, but we have to put ages for all of them because ages do matter. What do we learn about where ages matter? Aortic stenosis, where ages matter. If it's a young kid with aortic stenosis, what are you thinking? Congenital issues, bicuspid valve. If it happens later in life, mid-40s, 50s, rheumatic, or like Marfan's, those connective tissue disorders happen a little bit later. And then late in life, degenerative, just normal aging. So like ages matter. So if you get a question and they have what's aortic stenosis? What kind of murmur is it? Systolic, crescendo, decrescendo. So if you hear that, aortic stenosis. And what else? Okay, risk factors we talked about already, and obviously atherosclerosis is the real cause of all this because of his risk factors. He's developing plaques, causing the occlusions to form, causing the chest pain with activity. And then, this is all messed up. I don't know why Anyway, shear forces with atherosclerosis, high blood pressure, smoking causes intimal injury. And then you get all the repair, which is where the foam cells come in. LDLs oxidize, cause trapping, free radicals. They all get stuck inside, endothelialized, and so forth. So lumen decreases in size, less blood supply to the area. Case 4, 35-year-old woman. So again, young woman with chest pain. Do you really think it's cardiac in nature in a 35-year-old female? Probably not, but let's keep reading. Pain is 8 out of 10. Retrosternal, sharp in nature. So it's like a stabbing pain, not a pressure or someone sitting on your chest. So already we're describing it differently. When you talk about chest pain to your patient, ask them, can you point to where it hurts? And if they take one finger, like it hurts here, that's costochondritis. Because it's just one little area that hurts. Here's your sternum, your cartilage is right there. They got a little inflammation, give them some Motrin, they'll be fine. If they're like, oh, it really burns right here, this is acid reflux. If they're like, oh, it really hurts on my chest, or like they'll use the fist, the Levine sign, like they feel like a weight on my chest, this is cardiac pain, this is chest pain. But if they're like, this hurts like this, or they point, oh, it hurts right here, trauma, coughing, something is causing a little pain right there, but it's all superficial. Radiates to the back, worsens with deep inspiration. Remember, cardiac pain does not worsen with deep inspiration. And pain improves when she leans forward. Okay, that's the clue. She's leaning forward to reduce the pain. When you walk into a room, see what your patients are like when you first walk in. Okay, observe. When you first walk in, observe what your patients, how are they sitting? What are they doing? If you see people who are like sitting on their phone, scrolling, all of a sudden you come in like, oh, they see a doctor, like, or you come in, they're like, oh, like all of a sudden their demeanor changes, the phone goes away, oh, I'm in so much pain, it hurts, it hurts, it hurts. Like, no, you were faking it, you were fine a second ago. So observe your patient. Flu-like illness several weekdays beforehand. We talk about pre-existing illnesses before they present with these problems. Past medical history is normal, meds none, social history is normal. Vital signs, anything out of whack there? Pulse, but again, she's in pain. High blood pressure, high heart rates are not always a bad thing per se. Your body is a way to fight off the stress that's going on. Sometimes I wouldn't do anything with that. Why am I gonna, she's stressed out from this pain that she's in. Of course it's gonna be high. So you don't really worry about that. So moderate distress from the pain, this is all mild erythema. She was getting over being sick. Neck, some LAD is still present. No JVD noted. Why is that important? Well, what disease are we thinking of right now? What do you think she has? Pericarditis, right? Young woman, recent illness, tripoding, chest pain, works with inspiration to relieve the pain. What problem can happen with pericarditis that can lead to elevated JVD? Pericardial tamponade or pericardial effusion. Those two things will cause you to have JVD. So because she doesn't have it right now, she's not that severe yet because she doesn't have those other symptoms. It's just probably just inflammation of the pericardium, the pericarditis, causing her to have these symptoms. She doesn't have effusion. Heart, did I mention anything? What would also have to be here for the heart? What would I have to mention? The physical exam finding for the heart, if it was tamponade or effusion. Muffled heart sounds. Go back to Beck's triad. Muffled heart sounds, hypotension. Do we have hypotension? Nope. We don't have elevated JVD. So we can assume so far that they're not in tamponade or effusion. Cardiac exam, high-pitched squeaking, to and fro murmur. What does the to and fro refer to? The timing. It happens during systole and diastole. A continuous. It happens on both phases. Why? Because the pericardium is inflamed, and every time you squeeze and relax, the pericardium is going to move, causing this high-pitched squeaking, coarse friction rub. They're all pathognomonic for pericarditis. Lungs are fine. Abdominal exam and extremities are within normal limits. They're okay. It's just the cardiac stuff. So pericarditis, Coxsackie virus, some sort of illness beforehand, and it's an inflammation of the sac around the heart. The friction rub, and then obviously those are the two worst cases if they moved on. Next case, 56-year-old male comes to the clinic for a routine physical exam, has not seen a clinician in 10 years. This is the one that shows up on a Friday afternoon at like 4 o'clock. If you've worked in a clinic, you know what I'm talking about. Blood pressure is 160/90, so that's high. Does he have high blood pressure? Yes, 140/90 is the cutoff. Above that is. What physical findings might be present if he's had long-standing high blood pressure, meaning untreated high blood pressure, hypertensive retinopathy, so little splinter hemorrhages in the eye. They don't like high pressures, they're going to burst. Bruits, okay? Listen for bruits, a turbulent flow. All from long-standing shear forces on the vessels, causing the injury, the repair's got to happen, causing the plaques to form. When you get plaques, the lumen gets smaller, less blood. So some complications of high blood pressure, obviously all these things in that big chart, that flow chart. But again, it depends on where what vessels are affected in what systems. And some other causes, these are your secondary causes. These are the known causes for high blood pressure. Pheochromocytoma is a tumor within the adrenal medulla. What hormones come out of the adrenal medulla? Your catecholamines, epi and norepi. So they have a tumor right in there, so they're constantly secreting epi and norepi. So those patients with a pheochromocytoma, their blood pressure could be like in the 300s. So they're at very high risk of strokes because they can bust those vessels, causing hemorrhagic strokes. Cushing's, renal, hypertension, estrogen, we talked about before. Other secondary causes, meaning there is a known reason for their blood pressure. Case 6. Young woman is brought to the ED by ambulance after a severe MVA, which is a motor vehicle accident. So crash. She's unconscious. BP is 64/40. How is that? Super low. Are the aortic and baroreceptors and carotid, are they even working at this point? Nope, they're below 70. So they're not even working to help get anything back. She's intubated and being hand ventilated. No evidence of any head trauma that can cause all this to happen. Pupils are 2 millimeters and reactive, and she withdraws to pain. Withdrawing to pain means the brain is still working. When you guys do your reflexes in PD, you do your brachial, your patellar, Achilles, those are spinal reflexes. They just go to the spine and come right back. When you do your Babinskis, the anal wink, which you guys don't do on each other, but it's there. We'll talk about that in neuro. The abdominal reflex. Those are brain reflexes. Those are testing brain function. Can that signal get from you twitching on the abdominal skin to the brain and come back? Those are brain reflexes. So the brain is still working. She withdraws to pain. Pupils are still reactive. So cranial nerve 3 is working, right? Pupillary response is cranial nerve 3. Cardiac, no MGR. What is that? Murmurs, gallops, or rubs. Lungs, clear to auscultation bilaterally. So the cardiac and pulmonary exams are okay. We get to the lungs, tense with decreased bowel sound. So the abdomen is expanding, it's very tense, and decreased bowel sounds. Extremities, pale, cool, and clammy. The pulses are thready. Is this patient in shock?
Yes.
Yes. Despite aggressive blood and fluid resuscitation, the patient unfortunately does pass away. So, the 4 types of shock, she had hypovolemic. Why? Why do you think she had hypovolemic shock? So she was in a motor vehicle accident. There was a crush injury. Now, abdominal swelling, reduced blood, bowel sounds. If you have all this fluid over the abdomen, all this bleeding internally, just like with the muffled heart sounds with pericardial effusion, you can't hear very well through liquid. All this internal swelling and bleeding, internal bleeding. She's continuously losing blood. You have to do surgery to clamp those vessels and clean them up. So why does she have pale, cool extremities? Again, inadequate volume to fill the blood. All the blood is shunted to the core to keep your brain and your heart working. They don't care about the extremities, so they're going to be pale, cool, and clammy. In this patient, again, hemorrhage, internal hemorrhage from the injury, from the car crash. You guys getting an understanding now how to kind of go through a question now, kind of pick things out? Now, these questions, if you notice, they all end with like signs and symptoms. That's where we end. When you get to cardio in the fall, they're going to say, well, they're in the hypovolemic shock. What are you going to do now? Or what are you going to do to test that? Or what are you going to do to treat that? Like, that's the next step. But if you understand the mechanism of why things are broken, then you as a clinician can treat things effectively. If you don't know why someone's sick, you don't know what you're treating. You're just be trying all these weird different things. Nothing's going to work. Okay, next one, 55-year-old male comes to the ED, increasing fatigue, shortness of breath, swelling in the ankles and legs. So shortness of breath, swelling in the legs, what are these signs of? I didn't say if it was one leg or the other. I just said both legs. It's not a DVT, because DVT is only one leg. I would put one leg swelling. It's probably heart failure. Okay? Okay? Has a history of hypertension and is not taking his medications. Has a 20-year history of heavy alcohol consumption. Does your heart like alcohol? Nope. It's toxic. And says he's reduced his alcohol. Blood pressure, is that controlled? No. Heart rate? No. Respirations? That's high. And obviously anxious and uncomfortable. A physical exam. Bilateral pitting edema, lower extremities. Bibasilar crackles. Heart sounds are distant. S3 is present. What does an S3 represent? Stiff ventricle. And JVP is elevated at 10 centimeters of water. What kind of heart failure is he having? Does he have left side? Remember, what is the most common cause of right-sided heart failure? Left-sided heart failure. He's got the left-sided because of the breathing issues, the right side because of the swelling in his legs. So let's get some labs. CBC is normal. BMP is normal. BNP is elevated. Why is BNP going to be elevated in this patient? They're fluid overloaded. What happens to the ventricles? They stretch. They get bigger. When they get bigger and stretch, they release BNP to help get the fluid off naturally. Chest x-ray, cardiomegaly. Why do they have cardiomegaly? Long-standing high blood pressure. So the heart is going to remodel itself. It's going to get thicker. Bless you. Pulmonary congestion. Why do they get pulmonary congestion? Left-sided heart failure. The blood pools in the lungs. They can't breathe very well. Echocardiogram. Left ventricular dilation and reduced EF at 20%. Is that a normal EF? No, very, very low. So he has a dilated cardiomyopathy. We notice in the echo he's dilated. We know in the EKG he's got cardiomegaly, heart remodeling. He's got dilated. And what was the main reason, you think, or what, there are two main reasons why he has a dilated cardiomyopathy? Hypertension. What are some causes of a dilated cardiomyopathy that this patient has? We mentioned it before. Look at his medical history. Don't think everything is always clinical. What is his history? What does he have? What does he do? Alcohol. Remember, alcohol is toxic to the heart and it causes long-term alcoholism, dilated cardiomyopathies. Okay, heart chambers enlarge, the walls get thin, the contractile properties actin and myosin don't line up. Risk factors for developing dilated cardiomyopathy, obviously, is the alcoholism and chronic hypertension. And BNP, we talked about that already. Heart gets pumped out because more blood is coming through the system, because with congestive heart failure, you're a volume overload. Too much volume in the system, so all the chambers get bigger to accommodate the extra blood. Ventricles don't like it. They release BNP. Sarah, 10-year-old girl, brought to the emergency department by her parents. Known history of severe peanut allergy and previously experienced mild allergic reactions like itching and hives after accidental peanut exposure. However, this time her symptoms have gotten worse. So we're talking about a peanut allergy. What type of hypersensitivity reaction? Type 1. Remember what happens every time you get exposed to these things again? Gets worse. You've already primed your system, so every continuous exposure, it gets worse and it gets worse. So they bring her in, facial swelling, difficulty breathing, rapid heart rate, anxiety, hoarseness and stridor, nausea and vomiting. Okay. All makes sense because obviously they're having soft tissue swelling, smooth muscle swelling, bronchial swelling, can't breathe very well, the stridor from turbulent flow of air because of the swelling going on. Anxiety, rapid heart rate, of course, you're having problems breathing. I'm sure you'd be very stressed if that was happening to you. Nausea and vomiting from the episode itself. So they come in, distress, blood pressure is that low, especially for a child. Heart rate 140, very high. Respirations, high at 30, very tachypnic, trying to catch your breath. O2 sat, low, 88%. Physical exam, marked facial swelling. What's that known as? Angioedema. Urticaria, which are hives all over the body, and obviously wheezing on the chest. So this is a type 1 hypersensitivity reaction. It's IgE mediated. And obviously histamines is a big reason for all this. Histamine drop or gets dumped into the system, causing edema of those smooth muscles and swelling. Case 9, there's only 10 of them. Look at who all you guys do on your own. David Johnson, 65-year-old male, comes to the ED with complaints of fever, lower abdominal pain, dysuria, painful urination, and confusion. Reports he's been feeling unwell the past few days and the symptoms are getting worse. Fever, abdominal pain, dysuria, confusion. Is this infectious or inflammatory? Infectious. They have a fever. Okay? Always trying to figure that out. Is this an infectious process or is this an inflammatory process? Infectious processes will cause inflammation, but the underlying cause, why are they having this issue? Try and always figure out, again, why are you here? Okay, examination, acutely ill and confused, temp 103, heart rate 120, blood pressure is low, respirations is high. Physical exam, lower abdominal tenderness, CVA tenderness on the right. What are you testing for on CVA tenderness? Kidney stones or just kidney irritation. Any type of irritation in the kidney, if you tap on it, it's going to hurt. Kidney stones, renal capsule is tight, it's going to cause pain. For the most part, again, UTI probably. Urine output is diminished and he appears dehydrated. Blood, CBC, elevated white count with a left shift, and that obviously indicates that they have an infection. So we know they have an infection. Where is it coming from? So once you know your patient is infectious, your next hunt is to figure out where is it coming from. Usually if it's on the skin, they have an abscess, you'll see the redness and the swelling, and you'll look at that. You'll know, okay, that's where it's coming from. Other ways, you may not know. Urinalysis, presence of pyuria, so pus in the urine. Bacteria, so bacteria in the urea, and hematuria. So we have pus, blood, and bacteria in the urine. Urine culture and blood cultures are positive for E. coli. Why is this important to know? The different stages of sepsis. One is when you have a documented source, and one is when you don't have a documented source. We have a documented source of the infection. So how would you classify this patient? SIRS sepsis or severe sepsis? This is severe sepsis, all classifications of the SIRS with a documented infection, but they also have confusion, which is end organ stress, end organ damage. It's transient, it'll go away, but they're having some issues. Yes?
Is the decreased urine output also a sign of that? Or is that just from the UTI?
From ETI. Okay, They're not in shock per se. Their BP is relatively okay, but we don't know if they were unresponsive to fluid or pressors, but we know what their pressure was. So this is severe sepsis. Next case, gradual onset of shortness of breath during physical activity, such as walking upstairs or light gardening. Some occasional episodes of chest discomfort with exertion. Past month, got some dizziness, near syncope when he stands up suddenly. Denies any orthopnea, paroxysmal nocturnal dyspnea, or palpitations. No history of upper respiratory infections, fever, or weight loss. So just occasional chest pain with exertion when he's doing stuff. Medical history, hypertension for 10 years, hyperlipidemia 7, diabetes for 5. Family history, is that significant? Yep. Smoking history, yep, significant. So vital signs. Blood pressure, 140/85, is that okay? No. On the high side. Heart rate, it's okay. Respirations, normal. O2 sat, normal. General appearance, slightly overweight. Not really obesity or anything. Cardiac exam, no visible JVD. PMI displaced laterally to the midclavicular line. Why would that happen? Why would the hypertrophy of the left ventricle will displace it laterally, the point of maximal impulse, PMI. Systolic thrill, palpable over the right upper sternal border. S1 is normal, S2 is single and soft. So when you have a soft S2, that's also indicative of something. Now, also on the cardiac exam, 3 out of 6 harsh, crescendo, decrescendo, systolic murmur. Best heard, right upper sternal border. What valvular area is right up here? Aortic. So we know we have an aortic valve area, crescendo, decrescendo, systolic murmur. What valve is it? Oh, aortic, but I'll go on to this next part. The murmur decreases with intensity with the Valsalva maneuver. Why is that important to know? HOCM versus AS. Okay? So this murmur decreases. Aortic stenosis. Lungs. Clear to auscultation bilaterally. No adventitious breath sounds noted. Abdomen. NTND, non-tender, non-distended. Okay, my advisees, take notes real fast. Don't write novels. You guys are going to start writing notes this fall. You're going to write 2 of them for PD. Your advisors will read them and go over them with you and start writing your own notes this year. But they're going to be based off of like random stuff. It's not going to be like out of a textbook and you're going to write it. It's going to be off of something. You guys will write your own notes. Extremities, they're fine, no edema, and pulses are fine. So what symptoms do we have? We have high blood pressure, we have a murmur, shortness of breath, PMI is displaced, so we have left ventricular hypertrophy, all due to certain issues. EKG. EKG shows LVH. You'll learn why an EKG can show left ventricular hypertrophy. Has to do with voltages. You have more mass, you have hypertrophy, so more of a voltage is going to be seen on the EKG, and you'll see very, very tall R waves, which means more mass in the ventricle. Chest X-ray, cardiomegaly, so the heart got bigger because of the long-standing aortic stenosis and hypertension. Calcification noted in the region of the aortic valve. So we know it's calcified. Aortic valve area on EKG, so it's 0.8, which is obviously severe stenosis. EF, is that okay? 55? Yeah, that's fine. 55 to 65% is a normal EF. Concentric left ventricular hypertrophy. Why is that concentric important? Who gets concentric hypertrophy? Aortic stenosis patients will have concentric hypertrophy. If they have aortic regurg, then they're going to have eccentric hypertrophy noted. It'll be in the report. You're not going to have to figure this out. It'll be told to you, or it may say in a question like, you have a diagnosed a patient with aortic stenosis, what kind of changes would you see in the hypertrophy? And obviously concentric, eccentric, concave, and convex. I mean, you got to make up 2 other things. Yes? Oh, yes. So when you're in the hospital, order the test. Even though you may not be working in cardiology, if you're in internal medicine and admitting the patient or in the emergency room, order the echo. The echo tech, the ultrasound will do it for you, and then the cardiologist will read it and print the report. And then once it's ready, then you can read the echo report. But you will never have to read an echo. So that's the AS. So what 2 types of conditions can present with this type of murmur? AS and HOCM. Crescendo, decrescendo, systolic murmur. Yes?
So the only thing that differentiates is the murmur with Valsalva.
And this patient had aortic stenosis because the murmur got softer with Valsalva. Has to do with preload. Remember, in aortic stenosis, they need the preload to help push the blood through the system. When you do Valsalva, you increase intrathoracic pressure, which is going to decrease the pressure pushing on the atrium, so it pops open easier. So it decreases the preload. The decrease in preload means less blood is moving across the aortic valve, less sound. Less blood, less murmur, because the sound goes away. Murmurs are just turbulent blood across the valve. And that's it. Okay? Email me for questions. I will not be here tomorrow, but next Monday is Labor Day. You guys got a long weekend. Tuesday, and then Wednesday is your exam. You guys want the review Tuesday night again? Okay, yeah.
Are most of the questions going to be like this long, or
No, not all of them.
okay?